In this brief introductory segment, we're going to adopt a general perspective on the role of fluorescence visualization with VELscope in dentistry. We'll try to clarify and comment on what might seem to be some very simple questions regarding its use by general practitioners in everyday dentistry. What does the device do? What doesn't it do? In what context should it be used? How shouldn't it be used? This will put us on a solid footing as we move through some of the later segments that discuss in more detail the device's clinical usage. Before we talk specifically about the use of natural tissue fluorescence in the oral cavity, it's instructive to note that its use as an aid to disease detection and management dates back several decades. The lung was one of the first areas investigated, and there has been a lot of research published not only on the lung but also the colon, skin, and particularly the cervix. It's only in the past few years that researchers thought to apply this technique in the oral cavity. Perhaps the first commercial application of fluorescence imaging and visualization arose out of the pioneering work of clinicians and scientists from the British Columbia Cancer Agency in Vancouver, Canada. The OncoLife device, commercialized by a Vancouver-based company, Zilix Technologies, was a fluorescence-based endoscopy system used to help clinicians identify suspicious areas in the lung during a bronchoscopy. The promise of this technique led other major manufacturers such as Storz, Pentax, and Wolf to develop their own lung fluorescence endoscopy systems. When the scientists and clinicians at the BC Cancer Agency turned their attention to using fluorescence in the oral cavity, early promising results led to a partnership with LED Dental to develop and then later commercialize what came to be known as the VELscope system. Let's talk a little bit about how we should view this technique of fluorescence visualization. This slide is based on one that I saw from a presentation at an oral surgery meeting on different imaging modalities used to provide information on pathology in the head and neck region. It struck me at the time that this was a good way to introduce the concept of fluorescence visualization. Just like a lot of these other imaging techniques, panoramic radiography, CT, cone beam CT, MRI, PET, ultrasound, fluorescence visualization is not a standalone diagnostic test. It is another item in the arsenal of tools clinicians have to help them assess the health of human tissues. These techniques are inevitably part of a larger picture that includes a lot of other information from other sources. Also, they are more useful in some contexts than in others. The value they bring often depends on the particular type of clinical situation in which they are used. Like these other methods, fluorescence visualization with VELscope adds value because it provides visual information that cannot be acquired in any other way. The fluorescence response of warm mucosal tissue to violet blue excitation light. We'll see in later segments that this is very sensitive to disease processes occurring within the tissue. Also, unlike some of these other methods, ease of use is a big plus. Tissue can be visualized in real time directly with our eyes. For a permanent record, the fluorescence information can be converted into static images, or even movies without much difficulty. Every new clinical technique or tool requires some investment in time and effort to fully understand and appreciate. One of the primary values of fluorescence visualization with VELscope is as an adjunctive screening device to examine asymptomatic individuals to discover areas of concern that are subtle or otherwise might be overlooked during the visual and tactile exam. After the visible or white light exam, VELscope is initially used to provide a general survey of the oral cavity to enhance the visualization or discovery of abnormal areas. This can be compared to the type of information that a clinician may discover when viewing a panoramic radiograph, which displays information or conditions that were previously undetected during the visual examination. Once an area of concern has been detected, the clinician focuses their attention on the area, looking for details of how it presents. This might be compared to how an additional periapical or bite wing radiograph might be utilized after an area is discovered on a panoramic radiographic image. This additional radiographic view is beneficial to facilitate investigation of disease that is not readily perceived by the human eye. For example, a vertical bite wing for evaluation of bone loss in periodontal disease, or radiolucence of interproximal regions for dental caries. While radiography provides indirect visual images of human tissue that is displayed either on a computer monitor or on radiographic film, VELscope uses direct, real-time visualization of the tissue. Similar to radiographic interpretation and imaging, VELscope utilization requires an understanding of underlying principles, a sound background in anatomy and physiology, and an appreciation of normal variance. This understanding is a key to taking full advantage of the technology and using it to discover abnormalities that truly warrant further investigation. To summarize, VELscope is a survey tool, helps discover abnormalities that might otherwise have been overlooked, is initially unfamiliar territory and thus requires training and experience to fully utilize. Is best used as a survey tool that directs the clinician's attention to specific areas. And it's another means to visualize the disease process that complements rather than replaces the clinical impression. It facilitates rather than provides a diagnosis. And it is most definitely not a standalone diagnostic device. I think it's useful to go back to the FDA-cleared indications for use for the VELscope device. VELscope is intended to be used by a dentist or healthcare provider as an adjunct to traditional oral examination by incandescent light to enhance the visualization of oral mucosal abnormalities that may be or may lead to oral cancer and that may not be apparent or visible to the naked eye. Note the language here. Enhance the visualization of oral mucosal abnormalities. That is all oral mucosal abnormalities, not just dysplasia and oral cancer. Dysplasia and cancer are noted in particular, to be sure, in the blue text, which was cleared in a second FDA 510K based on published research in the literature on its cancer-related application. Also, some of these changes, visualized through VELscope, can easily be missed with the naked eye alone. But the VELscope should be considered as a general tool to help the clinician focus on any abnormality that may present in the oral cavity. Now let's look at the second indication. The device is also intended to be used by a surgeon to help identify diseased tissue around a clinically apparent lesion and thus aid in determining the appropriate margin for surgical excision. This claim is based on some outstanding research published by the BC Cancer Agency researchers in Vancouver, Canada, relating to the device's utility for the surgeon in helping identify dysplastic or outright cancerous tissue outside what was considered to be the clinical extent of the lesion using white light alone. Again, note the language. It doesn't say determine the surgical margin, but aid in determining the surgical margin. As for the general examination claim, the VELscope provides new information to the clinician to help him or her make a better decision. It doesn't make the decision. In my opinion, that is best left to the human brain. The FDA like to consider the so-called always-never rule when they clear or approve adjunctive medical devices. In this case, this isn't just regulatory red tape, but comprises a great deal of wisdom. Before you use the VELscope, always perform the traditional extra and intraoral head and neck exam first so that you can formulate an unbiased appraisal of the clinical situation. Then use the VELscope and never, based on this adjunctive exam, remove from consideration an abnormality that you would have otherwise investigated. If your clinical instincts make you suspicious of a particular area based on the traditional exam, then arguably it doesn't matter how it presents through the VELscope. Remember, clinical judgment is paramount. A detailed discussion of the traditional extra and intraoral head and neck exam is beyond the scope of this presentation, although it is the central topic of another module in our online education series. However, we wouldn't want to go any further before reminding you of its crucial importance in a comprehensive oral assessment process. It is the cornerstone of all complete and thorough examinations of the oral cavity. Moreover, it is essential for the appropriate utilization of any adjunctive methodology, including VELscope. If you pick up the VELscope without first having conducted an examination under white light and palpation, you're doing it wrong. The strength of the fluorescence visualization exam is the additional and different information it can provide to the clinician. It's not better than white light exam and palpation, just different. It is certainly not a replacement for this exam, nor is it a replacement for sound clinical judgment. The best decision for your patient comes from considering all the information available that includes not only physical examinations, but also medical history, risk factors, etc. In fact, as you'll be reminded when we start looking at the clinical cases, knowledge of an area's appearance under white light is crucial to making sense of its appearance through the VELscope. Of course, the physical examinations, whether of the traditional variety or adjunctive in nature such as the VELscope exam, are themselves part of a larger oral assessment process that also involves acquisition of a comprehensive health history through such tools as questionnaires and direct patient interviews. This diagram that attempts to illustrate the diagnostic process for oral mucosal lesions may be helpful to remind ourselves of its holistic nature and the interdependence of any one part on the other parts. Initially, we see the traditional process without an adjunctive aid such as VELscope. First, a health questionnaire and patient interview that establish risk factors and other information, for example, prescribed medications, that may be relevant later. Also, the patient interview is an ideal opportunity to provide patient education on oral health. Then the physical exam is conducted, traditionally the intra and extraoral head and neck exam, which allows for lesion discovery. Based on the health history and physical examination, the clinician then utilizes clinical judgment to formulate a differential diagnosis with referral for biopsy as appropriate. Histopathological analysis of stained tissue sections from a biopsy remains the gold standard for diagnosis of lesions in the oral cavity. The histological diagnosis then needs to be viewed in the context of all the patient information acquired through any of the questionnaire, interview, or physical examination to formulate a treatment plan for the patient. If we now add an adjunctive VELscope examination into this picture, we see how it fits in after the traditional head and neck exam as an additional physical examination and enhances the clinician's ability to discover oral mucosal abnormalities requiring follow-up. The holistic nature of the process remains the same whether or not we use the VELscope, and we can see how misguided it is to consider the VELscope examination as some sort of standalone diagnostic test for oral cancer. Although we have focused in this introduction primarily on the use of fluorescence visualization in everyday use, it's important to understand that its role as a tool in dentistry can depend on the context of its use. As we have seen, for the primary care practitioner, such as a dentist or hygienist, it's primarily an early discovery tool, highlighting areas for further investigation that otherwise might have been overlooked. This can take the form of outright discovery of an area that was missed by the traditional exam, or increased suspicion about an area that was already noticed but under fluorescence demonstrates characteristics that may cause concern. We'll talk a lot about this when we go through the clinical examples in the later video segments. For the specialists, such as the oral surgeon, periodontist, or the dentist, if they are so inclined, the tool can provide information that aids in the decision about the best location to biopsy the area. We've already touched on the utility for the surgeon as a tool to help identify the full area of abnormal tissue around a dysplastic or cancerous lesion, and thus aid in delineating the surgical margin for excision. Finally, after the therapeutic intervention has occurred, it is a tool for all members of the team to aid in the ongoing surveillance and monitoring of the treated patient. The point here is that this whole process of referral is maybe best thought of as a circle rather than a one-way path, with all members of the healthcare team working together and all playing their roles in patient monitoring and surveillance. Now that we are hopefully viewing this new and exciting fluorescence visualization technique with an appropriate perspective, we can move on to learning in more detail about how it works and what it can do. Oh, and you'd better get used to a new way of looking at things.